Okay, hello. Welcome back to Unraveled, Understanding Complex Illness. I'm Eileen Ruhoy.
And David Kaufman.
And if you are watching this on video and not just listening, you can tell that we are not in our studio, and it's because of the holidays, our travel schedule, and family stuff. And we wanted to make sure that we got an episode recorded for our subscribers. So we're just doing this via Zoom, but the next, from the next episode forward, we will always be in our studio, is our plan at least.
Right, but it would be helpful to give us some feedback on how this format works from your subscriber listener perspective. In some ways, it's easier for us to do it as a Zoom, although we miss being in the same room together. So let us know what you think.
Yes, yes, absolutely. And so today we decided to chat about immunomodulatory therapies. I do a lot of immunomodulation. Do you hear feedback in the noise?
Mm-mm.
Okay, I do. I hear feedback. I hope our subscribers don't, but we'll just continue. So we decided to talk about immunomodulation because we both do a lot of immunomodulation.
Are you saying you hear feedback or echo?
Echo. I mean, that's feedback.
Yeah, that's going to be a problem for people. All right, well, I don't hear anything. For me, it's
I
okay.
only hear it when I speak,
Yeah, maybe because of the headset.
possibly, but I don't
Okay.
have a headset.
Okay.
You're much more tech savvy than I am.
Yeah, with my 1999 headset here. Okay.
I sent my husband with the dogs out of the house so that he didn't make any noise because I don't have headsets.
Okay.
It's canceling earphones like some people have. Anyway, um, we do a lot of immunomodulation. And so
Yeah.
that's why we wanted to talk about it because I know that I spend a lot of time explaining to patients why I'm recommending a particular immunomodulatory drug, what I think it'll do, what my expected outcomes are, what we're going to monitor with regards to side effects and toxicity. And so I do it so often that I thought it would be a good topic to chat with you about because I would love to even hear how you approach this.
So, let's pull back a little bit and immune modulation doesn't always mean a specific drug. I think we're going to spend most of our time discussing immune modulating interventions, but I would want to emphasize that anything we do to help stabilize a patient, reduce their inflammation, manage their POTS, manage their MCAS, manage their leaky gut, will have a modulating impact on the immune system, usually in a very positive way. So I think, a really important thing for people to understand.
That's an excellent point, right? So the immune system obviously can be affected in all kinds of manners, and it doesn't necessarily have to be one of these immunosuppressant type drugs. I mean, even the foods we eat can affect how our immune system is functioning, So I agree with you. There's lots of ways that we try to manage immune responses in our patients, and not just with, fancy drugs. In fact,
Right,
I very rare, I mean, I never start there, I should say.
right,
Never
right.
start. And the only reason why I even started to go there more frequently than I had was just because of the experience that I'd had with plasmapheresis and how patients were responding. But as you know, plasmapheresis is super expensive. It's not easily accessible. And so, but when I saw the great response that patients were having for those who could not have plasmapheresis, I thought, okay, well, let's figure out how more we can help to modulate your immune system. And that's when I started to use a lot more of these drugs than I really had ever used before. And to be fair, there are newer classes of drugs these days that are at our disposal. And so it made it a lot easier the fact that we had a lot of choices. Though, having said that, I still start with like the old ones, I mean, I start with corticosteroids, for example.
Right.
Uh, or even NSAIDs, you can start as simple as NSAIDs if we're talking pharmaceuticals, of course. Again,
Well,
in
yeah, I mean, in terms of modulation, the first drug I give almost every new patient, if they have not already gotten it, is low-dose naltrexone,
right.
whose one of its prime functions or mechanisms of action is modulating the immune system through
Right.
toll-like
Yeah,
receptors. So,
I agree. I mean, LDN has become definitely one of my favorite things to start with. And if a patient that I see is not already on it, I put them on it almost
right.
immediately. And so, yeah, I agree. LDN, but when it doesn't do its job optimally, then, what do you do next?
Well,
What do you do next?
what do I do next? Well, it depends on what its job means. it's not always clear to me when to intervene with stronger, in quotes, modulating drugs. I think you have way, way more experience than me in the immunosuppressive modulating drugs, and I'm anxious to hear about that today. Um, but as you know, besides LDN, I am increasingly prescribing rapamycin, which is clearly a modulating drug,
Absolutely. It's an mTOR inhibitor. So
and that's the role that exosomes play. It's, as you say, the role of plasmapheresis. Am I prescribing cyclophosphamide as an immunosuppressive drug? No, I haven't been doing that.
yeah.
But I know you, again, have more experience with some of those, so I'm really anxious to hear about it.
Right. Okay. So again, but I want to make it clear, I don't start there, right? So, and as you
Right,
know,
of
with
course.
that we share that I have used these drugs on, they have not responded to anything else. They continue to progress in their symptoms, and they are really at, severe states where it's just it's affecting them even more so with regards to not only their quality of life, but even their mental health. And
Right.
that of course, makes us very concerned. And so we work a little bit harder to try to get the symptoms under control, and so that's where I think, immunosuppressant kinds of drugs definitely have a role.
Yeah, I guess I want to reiterate what you just said in the sense that maybe this is a little bit too strong a way to say it, but the suppressive drugs are kind of a last resort after everything else is either failing or not succeeding adequately. I think my problem is because I come at so much of this from an infection perspective. Just thinking about immune suppression makes me nervous because what about the infections I might be missing? What if it's infections that's causing the illness and causing the immune disruptions and disturbances, uh, all of which I believe, in fact. So I think that's why I have not dived in the way you have with the immune suppression.
Maybe even maybe there's a benefit to my naivete on infectious disease.
Well, I think it's important. Yeah. I mean, this is how you and I and other people dealing with complex illness learn because you're not going to look it up in a book.
No, that is true. I agree with that. But also, I mean, a lot of viral infections are being treated with steroids, right? So it sort of shows that I think initially it's not a huge concern to use
Correct.
some
I agree.
immunosuppressant drugs because corticosteroids do suppress the immune system. And, I really like using corticosteroids. I mean, historically, we've always seen steroids as sort of a way to assess whether or not a patient will respond to further immunosuppressant therapy. And we've often said in neurology, like if you have a good response to steroids, then there's a good chance you'll have a good response to drug A, B, and C.
Right.
Because obviously keeping patients on long-term steroids is never ideal, but I'll also say that I don't think any of these drugs are ideal to being on long-term because that's where the toxicity really starts to rear its ugly head. But I still start with corticosteroids. There's dexamethasone and prednisone and
No,
prednisone.
I agree. I use those pretty liberally. Having just
Yeah,
said what I said, nevertheless, I do use them, the
right.
steroids liberally short term, and it can be incredibly helpful. And
Yeah,
as you know, I use a lot of uh, physiologic dosing of hydrocortisone, not pharmacologic dosing.
right.
And
Right.
there I have no anxiety at all. I think it's fine,
Yeah,
and I
and
see
it
great
really helps a
results.
lot of
Yeah,
people.
great results.
Sure. And this idea that, obviously it suppresses the adrenal gland function of steroids, I think, well, specifically like things like prednisone, if you can use it liberally for up to 3 weeks, like 21 days, and
Right.
not really worry that much about the adrenal glands. But regardless, I think I'm still conservative, and anytime I use any level of steroids, I always do a taper, but long term, of course, can cause things like elevated blood pressure, diabetes, even weight gain, rage, poor sleep. So, you don't want to be on them for a long period of time, but if there's a response, I think that is reason enough to try one of these newer drugs. So so there's different classes of drugs. So so if they have a good response to steroids, I will say that I still use some of the older ones, which we've often referred to as steroid sparing drugs.
Eileen, let's just be clear for listeners. When you say what you just said, you're talking about the use of prednisone or dexamethasone in doses of 40, 60, 80 milligrams of prednisone and, 4 to 10 milligrams of dexamethasone versus when we talk about hydrocortisone in physiologic doses, we're talking about 5 to 30 milligrams a day,
Correct.
understanding that a milligram of prednisone is equal to 4 milligrams of hydrocortisone. So there's a huge difference here. And I think it's very important for everybody to understand that.
There is huge difference. I mean, there are different kinds of steroids, and also the formulation of different steroid drugs is such where the dosing sounds different, but they're equivalents.
Exactly.
There's a lot. I mean, there's a lot of drugs that are like that. I mean, I always talk about gabapentin, and people are like, "Oh my God, 1,200 milligrams of gabapentin," and I try to explain the formulation of it is such that it's not really a high dose.
Right.
And the benzodiazepines are sort of similar in regards, like alprazolam, it's like 0.5 is equivalent to 1 milligram of lorazepam.
Right.
Yeah, you have to sort of go over that with patients a lot. I do that a lot because I want to give them perspective on the dosing that I'm
Yeah, I
recommending.
agree. I mean, that's true for everything, most of the drugs we use. So typical beta blocker, if I start somebody at 5 milligrams and they're nervous,
Right.
I'll say, look, the typical dose is 160 milligrams for hypertension. We're talking 5 milligrams. So,
Exactly,
yeah,
exactly. So when I say that I'm doing low dose, like I try to prove to them that this is really considered a low
right.
dose. So, but I think I use a lot of JAK inhibitors. So, where you want to suppress the pro-inflammatory cytokines. I mean, I don't know how much we want to go into the immune system, of course, because there's the innate immune system, the adaptive immune system. And there are a lot of, points along the way of the immune response pathways that a lot of these drugs sort of interfere on. Interfere, it's funny because
That too, that too.
interfere on that too. I meant interfere on. But and those are the newer class of drugs that I probably use more often. But like I was starting to say before you interrupted me, uh, was that I still go with the old guard first, because if there's a response to steroids, I use what we have always referred to as steroid sparing drugs. And that's in the class of things like cyclosporin and azathioprine and methotrexate, even Cellcept, so mycophenolate. I still will use those because those have been around, of course, forever. So there's lots of literature on them, and I have a real level of I don't know if it's like confidence or just comfort, maybe is the better word, of like knowing what I have to look for with regards to side effects and toxicity. I think the JAK inhibitors, though, are becoming more of an old guard, though. I mean, there are new ones coming out. In fact, I was just commenting to my husband last night. We were watching television, and there's like all these commercials for newer,
Unbelievable.
specifically JAK inhibitors, but this one was of names that I've never even heard of,
Yeah.
and they're all for rheumatoid arthritis or psoriasis, so they're just newer and newer drugs coming out seemingly every week.
Eileen, let me interrupt you again. Okay. And I think it would be helpful to explain to people, or at least discuss for a minute, why you or we would even consider using an immune suppressive drug. Why do we want to modulate the immune system in a significant portion of our patients? What's the deal? What's the problem?
The problem is that most of our patients, as we see it and as we believe to be true, are in this state of a perpetual immune response, a perpetual inflammatory response. And while inflammation that is short-lived and self-resolving is actually has a protective result, to be in a chronic inflamed state is not protective any longer. And in fact, it's what we know to be behind a lot of neurodegenerative and a lot of progressive disease, of which our patients fit into that class. I see
Exactly.
them as neurodegenerative diseases, but maybe that's because I'm a neurologist. But regardless, I think we would both agree that they are degenerative, they're progressive, they've been chronically ill, they're not getting any better. And
Right.
that's when we intervene with these drugs that will interfere in some part of the immune pathway. And, the immune system is very complex. And we've spent a lot of time, of course, discussing the innate immune system because that's where the mast cells sit. But then, it's also the natural killer cells and the macrophages and lots of other different cells that are involved in the innate, and it's not as a non-selective, like very fast acting kind of immune response. And when they fail, as it often does, especially in chronic inflammatory states, then the adaptive immune system is recruited by the cells, digesting these pathogens or toxins and then presenting them to certain parts of the adaptive immune system, which are really the lymphocytes, the T and B cells, and that then differentiates the cells into different classes of adaptive immune cells that make antibodies, for example, or just kill the cell directly via different mechanisms. And all of that is important, and the details of it are important, but I think beyond the scope of what our discussion is today, and maybe we could make an episode about the immune system, but the details of those different steps actually have points where drugs can act upon, whether it's suppressing or blocking or digesting. So that's why it is important to understand all that. And that's why all these drugs, the more we learn about the immune system, the more big pharma finds a drug to interfere.
Right. Right.
So, and that's why we've gone down this route with patients. And again, we've done IVIG for, I don't know how many years have we been and we've seen a response. Then we started doing plasmapheresis and we see a response. And so, and then again, a lot of these drugs, some of these drugs, of course, are just IV administration, which is much more difficult to do. And so I avoid those for the most part. But a lot of these drugs are just oral, you order them through your pharmacy, usually, especially the old guard. I never have a problem with insurance, ever.
Yeah.
So it seems like such an easy thing to do, other than the fact that there's concerning, you have to be concerned about side effects and adverse events and toxicity for the patient.
Maybe one of the ways to look at it for patients, or to explain it to people, is we're not looking to suppress the immune system. We're looking to restore homeostasis. We're looking
Right.
to restore the balance. And in all of these complex illnesses, and by the way, in aging, it is all a function of the loss of homeostasis, too much chronic inflammation, and that interventions, whether they are steroids or Xeljanz or
Xeljanz
plasmapheresis,
a lot, yeah.
are an effort to restore that homeostasis and put things back in order, with an equal balance. And that would include reducing autoimmunity while at the same time boosting immune competence.
I agree. That's exactly what we're trying to do. And when we do that, and to be honest with you, I don't think the particular drug is as important as what you just said, frankly. Like I don't, in general, I often get asked like when I choose what drug, and I don't really have a great answer. Sometimes it's really about, um, again, their response to steroids. So if there was a great response to steroids, then I definitely go with the more classic steroid sparing drugs, which is like azathioprine and methotrexate, which I like both of them a lot. Um, Sometimes I'll go to cyclophosphamide, as you had mentioned. Sometimes I'll go to cyclosporin, and then sometimes I'll consider some other drugs, but I really start there, and then and I'll just sort of see what their response is to that, and if it's not as a robust response as I would have expected from their response to steroids, then I might go to the JAK inhibitors, for example, or some of the or recently, as we've mentioned many times, I really do like rapamycin. I like the mTOR inhibitors for sure. I like tacrolimus also as one of the calcineurin inhibitors. So I've used a lot of tacrolimus as well, especially if there's any kind of, so sometimes a particular symptom will make me think of a particular drug. Like if there's swelling involved, like, with a lot of mast cell patients, they have swelling. I like tacrolimus for that. And, so, because I've seen the response to tacrolimus with a severe mast cell response that has a lot of flushing and swelling. I think of tacrolimus, but I do. So I don't think it's so the particular drug I don't think is as important as what we're trying to accomplish for these patients with using this class of drugs.
Right.
Then the benefits of them are when you find that right drug and you have a response. I mean, it really is like it's a miraculous thing, and then you could really optimize what's going on, with regards to dosing, with regards to even supportive care of the immune system. And even when you think about the mechanism of action of the particular drug that they're having a response to, you can further enhance that. Obviously, I never use two non-steroid immunosuppressants at the same time, but I will sometimes add some steroids. So if they're
Sure.
doing well on a particular drug and somehow they have a flare, I'll add steroids to it. I mean, listen, I think about my MS patients and I talk about this all the time. And in fact, I've started to consider using some MS drugs, like some of the interferons, for example, or Copaxone, so, but I think that, when I think of EMS patients, they're on all these immunosuppressive drugs and then they have a flare. And what causes a flare, by the way? So viral infection, it's the first question we ask when an MS patient, which I don't know if you know, but multiple sclerosis is now being, so now it's considered a post-infectious,
Right. EBV.
that part, right? It's now being considered in the class of like of the diseases that we treat, these chronically ill diseases like long COVID and ME/CFS. What happened to your lights?
I don't know. Just went out. All the lights went out, actually.
Ooh, did you lose power?
Well, I can. I'm on with you. I don't know
No,
what
but
happened.
it might be your Wi-Fi. It might be just fine.
That's so strange.
Look at where your laptop is plugged in. Does it still have the battery mark?
Um, yeah, I don't
Oh,
know what's going on. All right, so I'm in the dark. Doesn't matter.
um, so
I am in this subject anyhow. So
you are not. You are actually a lot more in the light than you give
okay,
credit for. Um, so, MS patients are on chronic immunosuppressant drugs, right? And yet they have a flare, and we throw high dose steroids at them, by
right,
the way, which I
right.
very rarely do for for non-MS patients. But I'll give them steroids on top of the immunosuppressants. And it really does help them get out of the flare. So, the other thing that I often say is that these responses just proves the idea that there's one, an inflammation behind it, and two, an immune response behind it. Some have asked me, well, what if this is related to a reactivation of a virus? And so that's why I'm having this flare. And that's when, that we start to worry about using these immunosuppressants. So it's like a chicken and egg story, right? So did they have reactivation of virus or even a new exposure to a virus
Right, right.
infection? Now they have a flare, or was the drug that I put them on now making them more at risk of reactivation of an already present virus that's been dormant and latent in their system for a long period of time? So, and I don't know the answer to that, to be honest with
Yeah,
you.
I
Worry about
think it's an important part of the conversation. In rheumatology, it's a pendulum issue, as is true in so much of medicine. So it used to be the pendulum swung over here, and most autoimmune disease was believed to be caused by infection. And so the treatments were antibiotics. And then Big Pharma invented all these biologics that cost a fortune, and the pendulum swung over here. And now that's what's used. Then there's almost zero effort to look for infection as a cause or a ongoing cause or a cause of flare. And I think that's very dangerous and unfortunate. Um, and I guess, I worry that we're treating the outcomes, not the causes, and that may keep a patient on a biologic for the rest of their life, as opposed to maybe if we jumped in and put them on an antiviral and suppress that virus, their illness would downregulate. So I just think it's important that we always keep that risk of infection in mind.
right. What is the risk of being on antivirals for your whole life?
Well, I mean, millions and millions of people are on drugs like famciclovir and valacyclovir for their entire life to prevent herpes 1 and herpes 2 recurrences. Millions and millions.
And are there any side effects of that
No,
or
no,
any interesting?
no. And back in, when I was doing HIV medicine, we would have patients on valganciclovir, Valcyte, for years and years and years. So they're very, very well tolerated drugs. Yes, you monitor liver function, you monitor blood counts, but it's very rare to have to make a change. So yeah, I think it's really, they're very well tolerated.
That's so interesting to me because maybe that is another route that we should consider trying. I mean, I'm sure you've done, I mean, you've put patients on
Yeah,
antivirals,
I use a lot of antivirals. Yeah.
but
I
do you
mean, I
take
don't just
them off
throw
at
them.
any- Mhm.
What was that?
Do you take them off the antivirals at any
I
point?
do. I do. And I usually only start them if I have a reasonable data set that suggests reactivation or activity of that virus. There are some other ME/CFS docs who just routinely put everybody on an antiviral thinking it's reasonable, and there may be some truth to that, but I
Mhm.
prefer to get evidence that there's activity or reactivation, and usually will then use it for 3 to 6 months to maintain suppression. Again, the goal being to restore immune competence. All right, because that
Right.
activity of the virus impairs the immune function, causes inflammation, think of MS. I mean, that's an end stage example of what can
Right,
happen.
exactly. And that's always my worry, of course, is that so I think right. I mean, I do worry that the immunosuppressant classes of drugs on a long-term basis, which, um, I have, to be fair, I haven't had anyone on it. I don't know. What would you consider long-term, I guess, is the question.
Or which kinds of drugs you're
For
talking about.
immunosuppressant drugs, for like JAK inhibitors, let's say, for example.
It's hard for me to answer because I just don't have that much experience with them.
Right.
I really just don't know.
Yeah. I mean, because I do have a concern that I'm suppressing the immune system enough where they are at risk of reactivation of a virus or just
So
at risk of more infections, which is a known risk of these drugs, by
yeah,
the way.
so I mean,
Not,
just look at
yeah,
look backwards in the literature for a second. So the biologics, which are drugs like Humira, okay, a tumor necrosis factor inhibitor. I think
right.
that's the way they define it. Patients on Humira, if they're responding and they don't lose their responsiveness, they can be on that for years and years and years and years and years,
Right.
seemingly okay. But there's a clear risk of skin cancer, a clear risk of other cancers because you've reduced immune surveillance, certainly an increased risk of infections. But those risks in the risk-benefit calculation are less than the perceived and actual benefits.
Well, if
But
you're
it's
using
still
it
a
for
concern.
indication of what the drug was designed for, right? So
Say that again, I'm sorry.
if you're using it for so all of those studies that sort of show that are about patients who have the particular indication
Right,
of that drug, whether again it's rheumatoid arthritis or or asthma, or psoriatic or arthritis, um, or eczema,
right. But we don't know in our patients. Is that
we
what
don't
you're
know in
saying?
our patients,
Yes, I
right? Which is
agree.
why,
I agree.
we take caution, and which is why I always go to it as a last resort, and I monitor very, very closely, and I start very low and I titrate up slowly. But I will say that patients respond and they
Yeah,
do well, which just then provides further fodder for me to sort of really think hard about how I can correct their immune response, certainly more safely for them, but a lot more effectively. I mean, what I love about steroids is that there's a short time of action until you get a response. With these drugs, sometimes not sometimes, most of the time, it doesn't happen right away.
right,
So
right.
that's and again, we always talk about how communication with our patients is so critical for our care, because I need to hear back, like,
Right.
how are you feeling? Like, is this not working for your body? And sometimes, even side effects that are commonly reported with these drugs, I mean, I hear different things from our patients. They often don't tolerate it gastrointestinally. They'll get neuropathy that will increase, which is, not a common thing with these drugs, especially the low dosages that I'm using. Um, and so I like the communication. I'm always sort of checking in on them. So how's it going? And anyway, so
Do you need to monitor labs when you have them?
I monitor labs really closely. It could lower, obviously, white blood cell count, which a lot of our patients start with low white cell count, right?
Right.
So I just make sure that it doesn't drop any further. I check their liver and their kidneys. I mean, based on the drug that I'm using, obviously either liver or kidney. I always check platelet levels. A lot of these drugs can drop platelet levels. Sometimes actually they can increase platelet levels. Some of these drugs can cause anemia. So I always check cell counts, liver function, kidney function, and I always add sort of just some inflammatory markers, the
So,
CRP and the ESR, which I don't find all that reliable, but I do.
yeah, they're not very helpful. I wish they were.
I
So it
know.
might be very interesting to run some viral panels on patients
Yeah, I
once you've
haven't
put
been
them
doing.
on there, you know?
That's a really good point. I should probably do that actually, and just sort of check to see how. So you mean for viruses that have already been identified? You know,
Well, I mean, you can assume, I mean, I check in the first visit, I check all of the serology for all of the herpes viruses, okay? But the truth is, we're all infected with HSV1 and HHV6 and EBV and CMV. Um, I mean, 90+% of us by the time we're adults.
mhm.
Um, and you can't always tell whether there's a reactivation issue, but it's useful to know in advance what the serology is, the antibodies. But you can also run PCR testing looking for viral DNA in the blood. And that's, the gold standard, for example, for EBV. That's one of the big discoveries with COVID, is that it causes EBV reactivation, and that likely is part of the whole long COVID picture.
Yeah, I mean, I agree with you, and I think I'm going to start doing that more and more now that I'm thinking about it. I mean, I was even recently reading, a lot of these drugs, of course, came from the cancer world,
Right.
transplantation world, and I was just recently reading about some of the cancer research actually with these drugs and some of the immune surveillance that these drugs have helped um, or suppressed actually in some respects. And so I learned a lot about. And of course, as you know, a lot of cancer is associated with viruses. So and they were sort of doing viral kinds of studies to sort of see if there was an increased risk of reactivation. I have to pull out that paper because now I'm forgetting the specifics and I want to share it with you actually.
Yeah, I'd like to see that.
Yeah, that was a really good paper. Anyway, but so I'm thinking about doing adding to my repertoire of labs that I do for monitoring purposes and surveillance purposes, which I think would be really useful for this patient population to learn more about. Um, and I'm always interested in sort of course, the mitochondria and its role in all of this, right? So like, the mitochondria, like I think about azathioprine and how it affects purine metabolism, and the mitochondria usually, provide the precursors for purines. Um, and so I often want, because it does that tricarboxylic acid cycle and the one carbon cycle, and so it provides the precursors for purines. And so azathioprine, though, which I use very regularly, it's considered one of the steroid sparing, does impair purine metabolism. And so, and I wonder, and it's very effective. And if the mitochondria are dysfunctional and they're not providing the precursors as they so regularly do, I wonder if there's a connection there. And then it leads me back down to sort of mitochondrial treatment, which we don't really have. We talked about that. But I think it's one of the things that and it's what led me to think about using a drug called Actos more often, which you probably have heard of, right? So yeah, and I think we talked about that with regards to one or two patients that we share,
Right.
because it's very mitochondrial protective and it supports the mitochondria. And so I haven't used it yet, but I really would like to consider using that one. And it's a diabetic drug. And of course, all these diabetic drugs are so popular these days, the GLP-1s, because they
Right.
cause weight
Right.
loss. This is obviously not about that, but it's really mitoprotective. And so I'm starting to think about doing a whole different class of drugs that are not necessarily in the immunosuppressant and immunomodulatory class, just because I want to be more, I don't know, savvy about this infection question, which has always been sitting in the back of my head.
Right. Right. Well, I think the point here is that we don't need immunosuppressive drugs to necessarily modulate and improve the immune system and reduce inflammation.
Right.
And that's what's so enticing about some of these other pathways with rapamycin and pioglitazone, which is Actos, even acarbose, which I've been reading a lot about. Here's a drug that's not even absorbed out of the gut, but if you look at some of its impact, it's unbelievable.
Yeah.
And it's got no side effects except gas. That's its side effect, you know? And it changes the microbiome, it improves butyrate production, it improves the immune system. It has amazing benefit if you read about it. I mean, and then again, I hate to keep linking it because I think patients don't like to hear it, but if you look at the anti-aging longevity literature, acarbose extends life in the mouse model 17 to 18%. Rapamycin was like 19 to 20%. And they both doing it by reducing inflammation. And I think that's why these drugs are relevant to our patients.
I 100% agree. And I think it actually behooves us and them to find drugs that are safer, yet provide really great benefit. And
Right,
so yeah, so while I'm more than happy to do immunosuppression, which I don't do infrequently these days, I do worry about things that because we just don't know. We don't know about what's underlying this disease, what's the underpinning pathophysiology that I could potentially be making worse by suppressing their immune system.
right,
Their immune system, it's what we're assuming is overactive and causing the chronic inflammatory state. Then there it just seems to make sense. And again, patients do respond, but it's the long-term effects that I worry about. It's not the short term. I knock on wood, I have not had a problem.
yeah.
Um, I have not had a problem, but I do worry about long-term effects, of course, of this
Well,
chronic.
sure. I mean, maybe we keep repeating this, but I think it bears repeating. There's a reason in our patients and in other people and other patients that there's a loss of homeostasis and a development of chronic inflammation. Something's causing that. It's not like, you took a walk and went into Whole Foods and you caught chronic inflammation. It doesn't work that way. There's something wrong. And and yes, most of the time in medicine, the reflex reaction is to give drugs to suppress that chronic inflammation, i.e., all these drugs we're talking about. But I want to just keep saying we should be looking for what's causing it in the first place. And that doesn't mean we can find it, but maybe in addition to looking, there are other ways to restore homeostasis that are not, quote, directly immunosuppressive, but ultimately achieve that goal, which is reducing the inflammation. I think it's
Right.
important for people to understand we're not using immunosuppressive drugs to suppress the immune system. We're actually trying to modulate the immune system, reduce inflammation back to a normal balance.
Right. And you regularly use rituximab. I mean, so that one you have had experience with.
I don't regularly use it anymore because of COVID, but yes, I have used it a lot. And that's a perfect example.
Yeah,
Yeah,
exactly. I mean, that COVID, it's a good point that you made. During the early COVID years, I definitely didn't do any of this kind of work because I was
right,
terrified. But in the past year or so, I've sort of upped my game with regards to immunosuppression and making sure everyone's taking precautions, which you always did anyway. But obviously, during the whole the lockdown and the pandemic and everything,
right.
it was terrifying. But yeah, I think now, are you going to start using rituximab more often now?
I'm still very, very hesitant to use it because the patients where it's come up the most are patients where I'm absolutely sure and have proven they have ongoing infection that I have trouble getting rid of. So it's kind of contradictory in my head. I'm going to remove their B cell function completely while they have ongoing infection. It's a very scary concept to me.
Right.
And that's kind of where this whole, where my piece of this conversation is coming from when I keep saying looking for the underlying causes and stuff. But Rituxan can be great. I mean,
Yeah.
it's my fear with Rituxan is once you infuse that first dose, you're done. You can't stop it.
Right.
Right?
That,
I can
yeah.
stop steroids, I can stop Xeljanz, I can stop cyclosporin, we can
Yeah.
stop Cellcept. Um, but once you give it that first dose, a week later, there's no B cells.
Right.
And that's
And
a
you're
big
stuck
deal.
there. Yeah, you're stuck there for a while.
Yeah,
No, for sure. And that's why I like oral administration. And again, it's why I love steroids because first of all, there's so many different forms of administration, but it's just this fast onset of like, did it work or did it not work?
right.
You don't have to wait weeks or months or anything like that. And if you need to stop it, you can just stop it. So I completely agree with that. I mean, I've always liked rituximab. In fact, I used to just do IVIG, and then if there was some response, but not a great response, I would do rituximab.
Yeah, and that's what I was doing pre-COVID, just like that. Right.
Right, right. So interesting. What do you think about the monoclonal antibodies?
Well, I think, they can be great.
Yeah,
And they're much more targeted. I mean, if you think of
very targeted. Yeah.
Rituxan as a shotgun, the monoclonals are more like a sniper rifle. They're going after a single protein or target, which can be great.
Mhm.
The problem is, or can be, that since the vast majority of our patients have mast cell activation, the monoclonals often cause or will lead to a flare of mast cell, just
That's
as
what I was going to
IVIG
say.
can
That's
too.
been my experience with the
Yeah,
monoclonal antibody classes. I generally, I don't, they're not my go-to drugs for that exact reason. And plus people tend to develop resistance to them is what I'm finding.
right.
So they have a lot
So,
of mast cell activity and then they don't respond to the drug. And so it's just been a waste of time and not
right.
any better. In fact, they're often worse.
So this whole conversation and the pluses and minuses are why, for me, it's either I tend to focus or at least read about it and want to learn and try the drugs like Rapa and Actos and Acarbose and even things like oxaloacetate, which are
Yeah.
ultimately dealing with the immune system. So that's one path, and not separately necessarily, but the other path is exosomes and plasmapheresis because they have no side effects
Yep.
and they are, in the case of exosomes, restoring homeostasis. I keep saying it, but that's to me what's so important to the immune system. And plasmapheresis is, you should talk more about it, but is cleaning out all the garbage that builds up in our blood
Mhm.
that is provoking constantly immune activation and chronic inflammation.
Yeah, and also I just want to add mesenchymal stem cells, I think are
Yes,
phenomenal.
yes,
I mean, they
yes, that's
really help
also
modulate the immune system. And, I obviously there's autologous and autologous and a whole other topic, but um there's a lot of literature on support and boosting of the immune system with mesenchymal
right.
stem cell
And
infusions. And it's used
the,
for exosomes, of course. It's of the same kind of mechanism of action.
I mean,
Uh
the crime here is that these things are very effective with almost zero side effects. They're just so
Zero
damn
side effects.
expensive
Yep,
that most patients can't access them, and
right.
it drives
And
me
not
crazy.
FDA approved. And not FDA
Well,
approved.
yeah, that too.
So, well, I mean,
Minor detail.
it makes it hard for patients to access it because
Yes,
a lot of
yeah,
doctors don't. want to sort of wrangle with the FDA, you know. So,
Right. Right.
but plasmapheresis, of course, is FDA approved, though not for this indication, you know.
Right.
Doesn't make it, it doesn't make it unethical or illegal in any way. It just means that we're using it off label and sort of repurposing it. But it does mean that insurance won't cover it. And so it becomes very expensive for patients. And but you're right, it doesn't suppress the immune system. So there's actually almost no toxicity to it. There are some side effects directly after a session, perhaps, but they're self-resolving and very tolerable and manageable.
I
But
mean,
really do remove a lot of these
yeah.
mediators and inflammatory provokers. Let's put it that.
I
I'm
mean,
trying.
going out on a limb here, um, if it didn't cost so much money, or if we had somebody with $1 million to support a study, I'd want to take 50 ME/CFS patients and 50 long COVID patients and plasmapherese them and monitor their outcome.
Yeah.
Yes, there wouldn't be a placebo control, but that's life, you know? I mean, I think that's could be a dramatic, informative study to do, but it's not going to get done.
No, it's not going to get done. I mean, unless one of our subscribers wants to support. I would love to do that study. I would
Yeah,
love to do it because that if we can do that study and actually prove the outcome that we see and publish it, I think that's a first step in getting insurance to cover it for sure. And then just making it more widely acceptable as a treatment option for our patient population, which obviously is really what our ultimate goal is. So
right, right,
but I'm here to say that I think that the appropriate use of immunosuppressant drugs should absolutely be considered. You know, you start with the corticosteroid. I mean, again, I start with everything else that we do. You know, the LDN, the NSAIDs, and then I start with the steroids. Then I start with the steroid sparing agents like azathioprine and methotrexate, cyclophosphamide, cyclosporin, Cellcept, which is mycophenolate, and then I'll go to the JAK inhibitors. Um, I'll use monoclonal antibodies that I've already sort of expressed, like I've just been disappointed in that class of drugs. I'll use the calcineurin inhibitors for sure.
so how do you decide between, say, Cellcept
Yeah.
and
Well, it's really
cyclophosphamide?
it's a it's a gestalt, it's
Okay.
so, you just do it for enough years, like you just start to feel like what a patient would respond to. Often it will depend upon the symptomology that they have. Um, Sometimes, I'll look at their labs and maybe they've always had like elevated liver enzymes kind of thing. A lot of our patients do have mildly elevated ALT and AST, and that might affect my decision, or they've had elevated creatinine in the past, or they already have a below low normal white count. And so like I'll just sort of I wish I had a blueprint to sort of actually describe to you. Uh,
Hmm.
don't. I'm always happy to go over an individual patient with you or with, I mean, I've done this with other doctors, as you know, actually, because you're
Yeah,
part of the
sure.
conversations that we have with other doctors, but, and just sort of make a decision and we go from there. Um, yeah, and actually, as you know, like I've recently started using drugs that you can't even get here in the US. So, again, I'm always just sort of thinking about things that I think would be in the best interest of the patient, which is obviously what we all do. But yeah, I'm sorry if I don't have more specifics.
Yeah,
I'm sorry.
that's all right.
Like, and again, it just speaks to like we always talk about this. Like when you sit in a room with a patient, sometimes you just sort of get a feel for what you need to do.
Sure. Well,
Or
and it also speaks to the trial and error process of getting feedback. And
absolutely.
you say, all right, well, I think we should try this based on these reasons, but I'm not sure, so we'll try it and you let me know, and then we can
Right.
switch.
That's
Yeah,
exactly right. I mean, and also sometimes it really depends upon the patient. I mean, for example, methotrexate is dosed weekly when you start it, right? It's dosed weekly. And so, and other drugs are dosed like twice a day. So if I think a patient that won't be compliant on twice a day dosing, and these are the kind of drugs that you really need to be compliant about. So if like I'm going to decide if it's helpful or harmful, like I need to know that you're taking it as prescribed. So if I feel like you'd be better off on just like rapamycin, it's dosed weekly, right? Initially. So, so if I think you'd be better off with a weekly dosing of something or twice a day dosing, I might even make a decision along those lines.
right.
So yeah, it's all over the place a little bit.
I mean, it's true for an awful lot of what we do.
I know. I know. Again, I always say to patients, like if there was a blueprint, then everyone would be cured.
Right, right, right.
So, but yeah, that's what I do. What do you do, David?
Well, like I keep saying, I don't have as much experience with some of those drugs, so I tend not to use them, and I
Understood.
probably should take take it on,
Yeah.
get the experience
Well, I'm here
and
to
start
help.
using them. Yeah, yeah,
I'm here to be a sounding board.
yeah.
All right. Well, I think this was a good conversation. Hopefully our listeners enjoyed it as much as I enjoyed talking about it. I love this
Right.
topic. I love the immune system. We
Well,
should be.
I think it's all about the immune system. I mean, I think that that is, the crux of the issue in our patients and in cancer and in
Oh yeah,
all the diseases of aging, all the neurodegenerative and atherosclerotic diseases. It's all the immune system. Um,
it's
I
system dummy.
what?
It's the
Yeah,
immune
right,
system.
right, right. And I think it's only in the last, I don't know, 10 or 15 years that medicine has come to realize that and redo its focus instead of focusing on, just to use cancer as a model for a second, focusing on killing cancer cells. The focus is now how do we make the immune system more effective and efficient and able to uncloak those cancer cells that have evolved ways to hide from our immune
That's
system.
exactly right. And I think
Yeah.
that's a great development in cancer
It's
therapy.
incredible. It's
Yeah.
incredible.
And I think are going to learn more from that research going on for our patients. And that's what I'm excited about, which is why now I'm reading cancer journals.
I
So
know. And again, it's the same. I know I keep discussing aging, maybe because I'm aging, but uh, there's just no doubt that the immune system declines with age, and that leads to all of these diseases of aging. And there's no
yeah,
lack of data to support that. NK function decreases,
absolutely.
you know, everything declines. And at the same time, certain things rise, and that's why some of these drugs are so interesting, like
Right.
rapamycin and Actos and acarbose and uh, 17 alpha estradiol, and a whole bunch of different drugs which are dealing with the inappropriate rise of molecules which are then damaging the immune system.
I
And if we
agree.
can do that, that's the game.
Yeah, as we age, most functions of our immune system decline for sure. Opsonization declines, presentation declines, surveillance certainly declines.
Right, right.
So yeah, it's a little terrifying, frankly, but
Well, more
yeah.
so for me.
Well, oral anything, David.
Right, right.
Okay, so all right, well let's say goodbye.
Okay. So I hope I'd be, as I said, curious to see what people say about this format. It does make it a little easier for us in terms of
But I
scheduling a
don't
little more
enjoy it as much.
frequently.
I just
I
want to
know
throw
it's
it out.
much better if we're in the same room
I
together.
love being in the same room with you.
Yeah, I
I
agree.
think our
I
energy really just sort of, I don't know, it sort of motivates me and gets me
Okay.
to talk about these topics.
So
Um,
we have two more sessions scheduled Ja in January, right?
we're recording 5 sessions
Yeah,
actually.
right. Two more recording sessions, so
Oh, right. And
five
then we have a
hours.
live
I
on
was
the
just
20th. Yeah.
right, and then we have a guest who I won't name yet, who's coming in February. And hopefully we'll do that more of that in terms of bringing on other people, both physicians, patients,
Yes,
whatever.
for sure. This is
Yeah,
a well-known guest, so I think it's going to be exciting.
yeah, I think so. It'd be very interesting.
Yeah, for sure. So thanks for joining us in our Zoom, our own, hopefully our only Zoom recording. But if this works for you guys, then we'll probably have a couple of others through the year when, for whatever reason, David and I can't get to the studio. It would be nice to know that this is a good option as a backup for you guys, but we obviously want to make sure that you enjoy it. So definitely give us feedback. But
Keep
thanks for listening.
keep the questions coming. I feel like there's been less commenting and questions lately when I
I think it was
log
the
on.
holidays. Yeah.
Yeah, probably. Okay.
Plus also, our last our last post was just Jen Bree. So our subscribers got early access to that. And then our last post was it went to the public. So there's been a few weeks since a new post, again, because of the holidays and everything else. So hopefully we're going to start up again now for the new year, 2024. Let's go.
Okay. Great.
And
Great.
yeah, so keep the questions coming. We really enjoy the comments and the questions. We like the interaction, and we have a lot planned for 2024. We have a lot of great topics planned, but we want to make sure that we're at least addressing topics that you're interested in. So
Great.
please just keep them coming.
Okay. Thank
Thanks.
you. Bye.